We're going to dive into this little video. The reason why I wanted to talk about this is because yesterday I had a patient who had a massive MCA stroke. And I typically go and look at the imaging. And so this time I didn't. And so I went in and basically I was able to extract where the MCA stroke specifically was because of my knowledge in neuro, neuroanatomy. So I'm going to teach you a lot about MCA so you can be an expert on this and start extracting and kind of like pinpointing where is the stroke without even seeing imaging. So you can see here on my left side, but here's on the right side, my iPad, and I will be looking down for, jotting notes, and then I'm going to explain to you the MCA. So the MCA, it's a very, very important artery, right? It's the most commonly affected vessel in the brain. And one thing that it was very interesting when I was researching this artery is that they said it's a hypertrophied, so meaning it's big, right? It's a hypertrophied lenticulostriate artery. So we're going to go through the lenticulostriate arteries in a little bit, but I just thought this was really interesting. And we know that this comes from the internal carotid, so a pretty big artery. And so one thing with the MCA is that it has different segments. So we're going to kind of review them and I'm going to show you. Now, if this is your first time in this channel, my name is Lily. I usually create videos and podcast episodes to simplify neuro and make it super, super simple in a way that it clicks fast. And this is specifically geared to physical therapists who love neuro. And so thank you for being here. Okay, so the MCA has several what's called segments. You can have the M1 segment, the M2, M3, and M4. Okay, the most important one and the biggest one is going to be the M1 segment. And here you can see in this image that the M1 segment is going to be, oops, that's not what I want to do. Don't be white. Okay, right here. So M1 segment, it's very proximal, right? And so here, what's important about the M1 segment is that as it passes laterally, so you can see it starts right here, right? And then it passes laterally. I wish I can make this thicker, that way you guys can see it better. Okay, so as it passes laterally, it's going to branch out into what's called the lenticulostriate arteries. All these branches right here, okay? So that is the M1 segment. Then we have the M2, which is typically the Sylvian, and I don't have a picture of it, but it's basically right here. This is the M2 segment. And then the M3 segment is going to be the cortical segment, as you can see it right here, okay? So it's going to start M1, M2, and then M3 right here, okay? And M4, I didn't picture it here, but there's a M4 segment, okay? So the one that I wanted to focus on, because when I went to see this patient had a massive stroke and she was deeply affected in the upper and lower extremities. And as you know, MCA typically affects the upper extremity more than the lower extremity. So I started to think about why was that, okay? So one of the things with the M1 segment is that when you have a stroke in what's called the M1 segment, or they also call it the stem, this is going to be a very profound stroke when it comes to motor. So like hemiplegia. So this is where you can start seeing that both upper and lower extremity, depending on the size of the stroke. But as I was assessing her, she was, upper and lower extremity flaccidity. There was, the upper motor neuron symptoms like Babinski, positive Babinski, sustained clonus, all of that really clearly. But just by looking at her presentation, she couldn't move the whole left side. So then she also had a right gaze deviation, which we'll talk about that. So, okay, so we said M1, M2, M3, M4, M1 as it comes laterally. We're going to look at the lenticulostriate arteries, okay, which are deep, very small arteries in the brain, okay? So since we're here, we're going to talk a little bit about the lenticulostriate arteries, okay? These are very, very, as you can see, very small branches of the MCA. Okay, so remember when I said that I was reading that the MCA is a hypertrophied lenticulostriate arteries? So I guess this is where it all starts kind of like connecting, right? So these are small branches of the MCA, very, very prone to hypertension. Okay, so very, very prone to hypertension. This is the main cause of stroke in these little arteries. The other thing about the lenticulostriate arteries is that they do not have collateral, or they do not have a lot of collateral blood supply, okay? So therefore, occlusion of these vessels is going to lead to, specific stroke syndromes, and is going to be pretty, you're going to see your pure motor stroke or pure sensory stroke or different types of stroke syndromes, very particular to the lenticulostriate arteries. But the lenticulostriate arteries, just look at where it is, right? So look at the image right here on your right side of the screen. And so, we have cortical areas, right? But then here we have subcortical areas. Okay, subcortical areas. So these arteries are going to supply subcortical areas. Now, what do I mean by subcortical areas? I mean basal ganglia, internal capsule, all of those deeper areas. So these are the two main areas that the lenticulostriate arteries are going to supply. So we're talking putamen, cauda nucleus, globus pallidus, and very important, internal capsule, okay? So when I saw this patient, very dense, very, very dense upper extremity and lower extremity flaccidity, no motor activation, I started thinking immediately internal capsule. Like, this has to be the internal capsule. Now, if you're wondering why internal capsule, this is because the internal capsule has the corticospinal tract, okay? The posterior limb of the internal capsule, I dropped my pen. The posterior limb of the internal capsule, the corticospinal tract is going to run through there. And so when you have a lesion to the internal capsule, you're going to see the corticospinal tract affected. Okay? So I hope this is all kind of like connecting in your brain. So I started thinking severe hemiplegia has to be the internal capsule. And so automatically I went, it has to be the M1 segment. And so I was making these hypotheses, right? So that is lenticulostriate arteries. We're going to see pure motor strokes. We're going to see, let me look at my notes over here. We're going to see pure motor strokes. We can see pure sensory strokes. We can see a syndrome that's called a dysarthria, clumsy hand. And then we're going to see not commonly mentioned called ataxia hemiparesis, not because it's attacking the cerebellum, because it's affecting the cerebellum, but it's affecting the cerebellar circuit, okay? Now, this is getting too complex. Let's go back to lenticulostriate arteries supplying deep areas, okay? Supplying mainly basal ganglia and internal capsule, okay? All right. Now, here I want to bring your attention to the cortical segment. Now, cortical segment, as you can see here, if you remember the homunculus, okay, we have, of course, I'm going to fail if I draw the homunculus, but let's try. This is the nice picture of a homunculus. So, gosh, well, okay, trunk, hands, right? And then it's like the legs. Wow. Okay. I promise my artistic skills are better than this. Okay. So we see, foot here and then trunk and head and, arm and all that. So why then MCA strokes are going to cause upper extremity and face weakness because of the area they supply. Okay, so they supply those lateral areas where all those areas that supply the face, the upper extremity, the hand, and all that. Okay, so that is with the M3 segment, cortical. Okay, so let's talk now about something that you've heard before, and it's the superior and inferior division of the MCA. Superior and inferior division of the MCA. So we talked about summary, we talked about M1 segment, which is going to be proximal, which is going to give out the lenticular striate arteries. Then we talked about a little bit about cortical. Okay, cortical. We're going to see your typical upper extremity face weakness, somatosensory for the face and arm, etc. But we're going to talk more about presentation when we go and talk about this specifically, because this is where it's going to click, beginning to click the superior and the inferior division. So we have the superior division, which is going to be basically, let me bring the highlighter. Superior division. Okay. Superior division. And then we have the inferior division. Superior division is going to supply most some areas of the frontal lobe. Inferior division is going to be temporal lobe. Okay, so superior division, we're going to see, let me put the pen. Superior. We're going to see upper extremity and face weakness. So your typical MCA presentation. But here in the superior division, we're going to see Broca's aphasia. The other area that the superior division is going to supply, it's going to be the frontal eye fields. The frontal eye fields. Why is my... Oh, there it is. Sorry, guys. Okay, so upper extremity and face weakness, Broca's, and frontal eye fields. So what are the eye fields? Remember when your patients are going to have a gaze deviation? So when they have a gaze deviation, that means the frontal eye fields have been affected, okay? Because the frontal eye fields are going to shift your vision contralaterally. So my left frontal eye fields are going to direct my eyes to the right. My right frontal eye fields are going to direct my eyes to the left. So if my left frontal eye fields are not functioning because of the stroke, meaning they cannot shift my eyes this way, they're going to stay in the initial position. So frontal eye fields, that's why you see that gaze deviation, okay? And the last one is the sensory problems with upper extremity and face. So that's the superior division, okay? Now here for the inferior division, we're going to see pretty much the same, but a couple small differences. For the inferior division, which is this, right, we're going to see Wernicke's aphasia. We're going to see the optic radiation affected. So the optic radiation is going to cause visual field cuts. Okay, visual field cuts, meaning that homonymous hemianopsia. Okay. HH. And the last part that I want to point out, so Wernicke's is of course going to be on the left side. On the right side, you're going to see those, since we're dealing with a little bit of the parietal on the inferior division, we can start seeing some visual spatial perception problems in the inferior division of the MCA, meaning this is where you can have the hemilateral neglect. Okay, so hemilateral or unilateral mostly. Why am I saying hemilateral? God, where am I getting those things? Es mi cerebro en español. On the right side. Okay, so superior inferior division, we're dealing with those specific things. The major difference is superior division is going to be Broca's and inferior division is going to be Wernicke's. Okay. Now, the last thing that I wanted to point out and see if you remember, this is again how this looks like when it's the M1 segment, which this ties back into my story of the patient. So this patient, again, dense upper extremity, lower extremity weakness, right gaze deviation. She couldn't speak, so she was almost nonverbal, is a massive stroke. And so after just the assessment, I was like, probably this is an M1 segment MCA stroke. And so again, M1 is going to be the proximal, and then it's going to give out, as it comes laterally, it's going to give out the lenticular striate arteries, okay, which is going to supply putamen, caudate nucleus, internal capsule. So when I went back to the EMR system, in fact, she had had a M1 massive stroke, okay? So that reminds you that even though you don't see the imaging, if you know where it is, how does it present, and you know the neuroanatomy, you can predict presentation. And this will help you a lot with the NCS, because when they present to you the case, which they will, basically they will present to you the patient presentation. And so if it says, this is a patient who had a massive stroke, in the M1 segment, what is the expected presentation? You can already know, okay, M1 is the stem. This one is going to give out to the lenticular striate arteries, which is going to supply this, meaning this patient will be dense hemiplegia, et cetera, et cetera. So, all right, guys, I hope that you found this video helpful. Let me know if you like this kind of videos. This is a brand new strategy of creating videos for you. I hope that you enjoyed this video, and I'll talk to you next time. Bye.